Okay, now, thank you, Ryan. So, hi everyone, I'm Skip from YINGCHI. Glad to see you again in 2022. Thank you for your love and support in the past 2021. Previously, we have discussed 8 topics plus 1 special topic about TMS. So this week will be the 9th, which is about TMS be applied in Parkinson's disease. So Parkinson's disease presents with both motor and non-motor features, and motor symptoms can respond to some therapies, but these treatments are often ineffective for non-motor symptoms, and depression is particularly common, with a prevalence range from 40% to 70%, so finding a more usable therapy to improve both the motor and non-motor symptoms means so much to patients. And before moving on to the main content, I want to thank the clinical medical engineer, Mr. Jin Zheng, for sharing his knowledge with us and helping make up the slides. These are our social media. Thank you so much for your attention to our official accounts. And now let's start. Please take a look at the contents. First, we may have a brief introduction to the Parkinson's disease. It is a brain disorder that leads to tremor, stiffness, and difficulty with walking, balance, and coordination. And one clear risk factor for Parkinson's is age. Although most people with Parkinson's first develop the disease at about age 60, about 5 to 10% of people with Parkinson's have early onset disease, which begins before the age of 50. Early onset forms of Parkinson's are often, but not always, inherited, and some forms have been linked to specific gene mutations. And Parkinson's symptoms usually begin gradually and get worse over time. As the disease progresses, people may have difficulty walking and talking. They may also have mental and behavioral changes, sleep problems, depression, memory difficulties, and fatigue. And both men and women can have Parkinson's disease. However, the disease affects about 50% more men than women. So this is the proposed timeline from onset to death in classic Parkinson's disease. A 40-year course is assumed, although it is inevitable that there may be considerable individual variability. And the various steps are presented in linear fashion, but the disease is likely to show an accelerated course in the later years. Baroque pathological staging is indicated in these Arabic numerals below the horizontal line. Above this line are the proposed symptoms in the prodromal phase, and to the right of this, the major features according to some studies. And the two symbols at the extreme left of the timeline represent two possible causative agents, genetic mutations or viral infections. It is uncertain whether the sympathetic nervous system is involved in Baroque stage 1 or 2. Hence, the pathology is indicated by arrows straightening both of these phases. And neurological disorders are now the leading source of disability globally, and the fastest growing neurological disorder in the world in Parkinson's disease. And from 1990 to 2015, the number of people with Parkinson's disease doubled to over 6 million. Driven principally by aging, this number is projected to double again to over 12 million by 2040. Additional factors, including increasing longevity, declining smoking rates, and increasing industrialization, could raise the burden to over 17 million. And in the early stage of Parkinson's disease, including the phase before dopaminergic treatment is initiated, and non-motor symptoms are more important for reduced health-related quality of life than motor symptoms, such as fatigue, depression, sensory complaints, and gait disturbance emerge as the most relevant symptoms and should be given corresponding attention in the management of these patients. As you can see in this graph, both the motor symptoms and the non-motor symptoms mean so much to the patients, and especially for the non-motor symptoms, as you can see in these, the symptoms listed here, has a great impact on the life quality of the patients. So what causes Parkinson's disease? A very simple principle is that the diminished substantia nigra causes neuron affected by Parkinson's and causing a diminished dopamine. And Parkinson's disease occurs when nerve cells in the basal ganglia, an area of the brain that controls movement, become impaired or die. Normally, these nerve cells or neurons produce an important brain chemical known as dopamine. When the neurons die or become impaired, they produce less dopamine, which causes the movement problems of Parkinson's. And scientists still do not know what causes cells that produce dopamine to die. And another factors appear to play a role in Parkinson's disease, including the genes, and researchers have identified specific genetic mutations that can cause Parkinson's disease, but these are uncommon except in rare cases with many family members affected by Parkinson's disease. However, certain gene variations appear to increase the risk of Parkinson's disease, but with a relatively small risk of Parkinson's disease for each of these genetic markers. And exposure to certain toxins or environmental factors may increase the risk of later Parkinson's disease, but the risk is relatively small. And these are some main symptoms for Parkinson's disease. And as you can see here, most of them are some motor symptoms, such as tremor, rigidity, bradykinesia, posture instability, and other symptoms, including non-motor symptoms, such as depression and other emotional changes, difficulty swallowing, chewing and speaking, urinary problems or constipation, fatigue, skin problems, and sleep disruptions. And also the diagnosis of Parkinson's disease is quite important, and for a number of disorders can cause symptoms similar to those of PD. And people with Parkinson's-like symptoms that result from other causes are sometimes said to have Parkinsonism. And while these disorders initially may be misdiagnosed as Parkinson's, and certain medical tests as well as response to drug treatment may help to distinguish them from Parkinson's. And since many other diseases have similar features, but it is important to make an exact diagnosis as soon as possible. And diagnosis is based, and the diagnosis for PD is based on person's medical history and a neurological examination. And there are currently no blood or laboratory tests to diagnose non-genetic cases of Parkinson's disease. So this is the 8-item version of the Unified Parkinson's Disease Rating Scale. It can be completed in about 2 minutes and is ideal to monitor Parkinson's disease clinical status, which is introduced in 2012. And the therapeutic goals mainly for the treatment of Parkinson's disease involve 3 important aspects. First, we need to help to slow the progression of Parkinson's disease, improve both the motor and non-motor symptoms, as we have mentioned before, that they may seriously affect the quality of life, and to prevent the motor complications. And currently, we have several ways to treat Parkinson's disease. And for the medicines for Parkinson's disease, we may say there is no cure for Parkinson's disease, and the drug therapy is the first choice and the main treatment in the entire treatment process. And the treatment method is disease modification treatment and symptom improvement treatment. And the medicines prescribed for PD includes drugs that increase the level of dopamine in the brain, such as levodopa, and drugs that affect other brain chemicals in the body, and drugs that help control non-motor symptoms. Other invasive therapies such as deep brain stimulation, and for people with Parkinson's who do not respond well to medications, and deep brain stimulation, or when we simply call it just as DBS, may be appropriate, and it is a surgical procedure that surgically implants electrodes into part of the brain and connects them to a small electrical device implanted in the chest. And the device and the electrodes stimulate the brain in a way, and it is used to treat such as tremor, slowness of movement, and rigidity. Other therapies may be used to help the Parkinson's disease symptoms as well, and they include physical, occupational, and speech therapies, which help the gait and voice disorders, tremors, and rigidity, and decline in mental functions. Other supportive therapies include a healthy diet and exercises to strengthen muscles and improve balance. So TMS is also used in Parkinson's disease in many aspects, and we will have a brief introduction to the principles and its mechanism behind transcranial magnetic stimulation. And TMS uses a time-varying pulse magnetic field to penetrate the skull to form an induced electric field in the brain's neuronal cells, and then generate induced currents to act on the nervous system, causing a series of physiological and biochemical reactions, and thereby affecting brain metabolism and neuronal excitability to improve and treat mental and neurological diseases. And its principle behind TMS is in electromagnetic induction. So it is painless and non-invasive. And the mechanism of TMS is to affect the processing of information by the nervous system, including neuronal synaptic excitation, synaptic inhibition, and synaptic plasticity. And the long-time potentiation and long-term depression caused by the high or the low frequency of TMS are important manifestations of the plasticity of synaptic function. And they are also the main basis for TMS to treat different diseases with different frequencies. And TMS can regulate the excitability of cerebral cortex, and it can achieve long-term cortical plasticity regulation and changes cerebral blood flow and metabolism using some imaging technology, and affect neurotransmitter secretion in brain tissue, such as BDNF and dopamine, or it can stimulate the secretion of neurotrophic factors. And since TMS is a non-invasive neuromodulation therapy, which applied both in neurological function tests and clinical treatment, first TMS can evaluate the function and excitability of the cortical spinal cord, and TMS helps improve motor and non-motor symptoms. This is the therapeutic guidelines, which was published in Clinical Neurophysiology by IFCN, and summarize the literature on the application of TMS in PD in these following aspects. So first, here is a level of B recommendation for Parkinson's disease to apply on motor symptoms. So this is a randomized, double-blinded crossover study, and 70 patients diagnosed as PD in this study was recruited, and the lower leg primary motor cortex, which is the M1 of the dominant hemisphere, is stimulated, and they are treated for 5 days sessions with a high-frequency RTMS by a double concoil. And as you can see, the results after 5 daily sessions of 10 Hz rTMS, the number of steps required to complete the standing start 180 degrees turn test and the freezing of gait questionnaire, which are the primary outcomes, and significantly improved and in the real as compared to the sham condition, with a benefit lasting for at least 1 week after the last rTMS session. And in addition, for the secondary outcome measure, which is the Unified Parkinson's Disease Rating Scales, has also improved in the real group. This is another multi-center double-blinded sham-controlled study in patients with idiopathic Parkinson's disease and bilateral motor, who has bilateral motor symptoms and comorbid major depression, and was randomized to one of 4 groups, which is to stimulate the bilateral M1 area or the DLPFC, M1 plus DLPFC or the double sham. And they are treated for 10 days with a figure of 8 coil. And you can see the results in the graph that for the 50 patients who have completed all study visits, and the real M1 rTMS results in greater improvement in motor function than sham at the primary endpoint. And there was no improvement in mood in the DLPFC group compared to the double sham group, as well as no benefit to combining M1 and DLPFC stimulation for either motor or mood symptoms. And as you can see in these 2 studies, and Parkinson's disease can also help in levodopa-induced dyskinesia. And the first report of rTMS effects on levodopa-induced dyskinesia was published in 2005 in this pilot study of 8 patients, and the LIDS were reduced following a single session of 1 Hz rTMS delivered bilaterally or the SMA. And the same group replicated this results in PD patients in about 2006, and without finding any enhancement of effect or prolonged benefits after 5 sessions. And in 2009, one study reported a significant reduction of levodopa-induced dyskinesia after reported daily sessions of 1 Hz rTMS of M1 contralateral to the most affected side in a crossover study of 10 PD patients. And some study may also apply the cerebellar CTDS, which to treat the levodopa-induced dyskinesia in Parkinson's disease patients. And as you can see, the results compared to the sham group, the CTBS group has a significant score reduction. And also in the therapeutic guidelines, the depressive symptoms for the Parkinson's disease patients also acquired a level B recommendation. And in this study, 46 patients with Parkinson's disease, they have mild to moderate depression, and they were randomly assigned to active and the sham rTMS group to stimulate the primary motor area, which is the M1 area, for about 10 days. And as you can see, the results, these results have showed an improvement of depression scores by 59% on the MADRS and 50% on the back depression inventory after high-frequency rTMS of bilateral M1. And still, further study needed to be done concerning its effects. And for the dysnomia, and as you can see in this graph, the PMC target has not proved its interest in dystonia. And at present, as present. More recent studies aim at investigating the value of cerebellar RTMS in this clinical condition. Further evidence of the value of cerebellar stimulation in dystonia is still needed. And while there are several studies that demonstrated the effectiveness of TMS, and further evidence of the value of hot side stimulation in dystonia is still needed. And for the essential tremor, in this study has showed has showed that there are some still need more data from literature to study the use of RTMS in treatment of essential tremor. But here is a good results from Dr. Jin Zheng in West China Hospital. And in this case, you may see that this is an old lady who has been diagnosed as Parkinson's disease for almost a decade. And the most obvious symptoms for this old lady is dyskinesia and tremor. Also, she has a bad temper and she has depressive symptoms. And as you can see from the video that before and after the YINGCHI TMS therapy, she has achieved great results, and her tremor is improved a lot, and she seems to be calm after even one single session and 2 sessions of TMS therapy. Finally, as for the restless leg syndrome, and it is also one of the complications of Parkinson's, and the effectiveness of TMS on its action has been demonstrated as shown in the left. A significant reduction of the IRLS-RS score was found in the real but not the sham group, which is the restless leg syndrome rating scales, and up to 78% decrease at the completion of the 10 sessions. And in 5 patients who have been not improved by sham RTMS, this score further decreased after switching to real RTMS. However, no additional follow-up was available, so it is impossible to determine whether this intervention has a clinical relevance or not. And these are some protocols in the therapeutic guidelines. And this is the protocol cited from the nervous system diseases transcranial magnetic stimulation treatment, which is added by Guoyi from Shenzhen People's Hospital. And these are some protocols cited from Sichuan West China Hospital, which is added by Dr. Jin Zheng. And these are some protocols from some cited studies. So in general, TMS has achieved good results in the treatment of Parkinson's symptoms, such as motor symptoms, and also has non-motor symptoms. And as we all know, most patients are seriously affected by the non-motor symptoms. They may have poor sleep and they may have depressive symptoms, but a large number of clinical trials still needed to further explore the potential of TMS. And thank you for your attention. You can list or ask directly your questions